most of the this may explain but the outpatient having a fetal hemoglobin explains why they weren't in crisis as compared to the inpatient. Copper, zinc and total antioxidant capacity had a weak positive correlation with the fetal hemoglobin in the outpatient. And copper and zinc had a positive correlation with the fetal hemoglobin in the outpatient. And for zinc, it was consistent with this study. Though for copper, it rather had a negative correlation with the fetal hemoglobin in this study. And also, fetal hemoglobin at different stages of sickle cell anemia had different correlations with zinc and copper. The 8-OHDG, which indicates DNA damage, was much lesser in the sickle cell inpatient as compared to the rest. This could be because the sickle cell patients on admission were constantly hydrated, and as such, reducing the hemoglobin concentration of the sickle hemoglobin S in the cells, which will decrease the propensity of the cells to sickle. And also hydration prevents vaso-occlusive crisis, which also will prevent oxidative stress leading to DNA damage. As such, it was reduced in the inpatient. And also, consistent taking of folic acid also prevents this DNA damage. That explains why the DNA damage was lesser as compared to the controls. And also, their total antioxidant capacity was higher in the inpatient as compared to the rest. And this is also consistent with this study. The total antioxidant capacity being higher in the inpatients was rather in disagreement with this study. Zinc levels were higher in the sickle cell inpatient as compared to the outpatients. Zinc is important, but the red blood cells are important storage sites for zinc. And since we were being constantly hydrated, there was less possibility of the cells breaking to release the zinc. And as such, the inpatient had a higher zinc level as compared to the outpatient. And copper was higher in the inpatient as compared to the outpatients and the controls. The controls having a higher zinc level than the outpatients was consistent with these two studies. But however, the inpatient having the higher zinc levels than the outpatient was not in agreement with this study. And also the sickle cell patient having the higher copper levels than the controls was consistent with this study below. In conclusion, the intravenous hydration therapy given to sickle cell inpatient might have provided a protective effect against oxidative stress. This might suggest that the management of sickle cell anemia children in the form of hydration when on admission is beneficial, and micronutrients should be taken into consideration in therapeutics for sickle cell anemia patients. And more work should be done for the other various forms of sickle cell disease. My reference, acknowledgement.
Thank you very much, Amma, for the insightful presentation. Any question for Amma concerning the interplay? Any question?
Hello, thank you for a very nice presentation. Please, how did you measure the fetal hemoglobin?
Thank you. I measured the free fetal hemoglobin found in the serum. That's why I'm using the ELISA.
Thank you. That's why I was asking that question was because the distribution of the genotype, you said these were children who had sickle cell anemia. So the assumption is that they are SS or they are FF, depending on whether there's a hereditary persistence of the fetal hemoglobin or not. So if initially, the thing I saw was electrophoresis. If you're using electrophoresis, if the quantity of the fetal hemoglobin is very small, it's very difficult to be able to even see it in the first place. So if you use something that is quantitative, then you can be able to. So it's not that you're sure that if it was the ELISA you used to quantify it, you could have equally used an HPLC too. Thank you.
Yeah.
About your methodology, you use or you analyze zinc and copper. I'm thinking why out of the lot micronutrients you concentrate on zinc and copper. And secondly, you said you excluded other causes of hemolysis, such as what and why?
Thank you. Zinc and copper, they serve as cofactors for superoxide dismutase, which is an antioxidant. Measuring oxidative stress, which also hemolysis comes to play with it. And also some of the micronutrients, when hemolysis affects them too. So I had to rule out the other causes of.
Thank you very much. Any other question? Otherwise, let's give a round
Yes,
of
please.
applause.
Yes, please. There's a question here.
Okay, sure.
Yes,
Professor.
I was not here from the beginning, but I heard you mention that between the inpatient and the outpatient, the zinc levels were higher in the inpatients than the outpatients. Were the inpatient receiving any supplements of zinc because of their condition? Or if not, then are these patients coming from the same environment, eating the same kinds of food? Because the levels of zinc in food can vary from one nutrition state to the other. So I'm just wondering why we can just conclude that inpatients more than outpatients, right?
Okay, thank you. Please, for the levels of zinc, well, my explanation was based on the management of sickle cell anemia. They are mostly hydrated, and zinc is mostly found in these red cells. And with erythrocyte dehydration, it causes the hemoglobin S to sickle. It causes the cell to sickle when the concentration of hemoglobin S increases due to dehydration. And this causes the sickling to leads to hemolysis. But since they were being hydrated, I concluded that that wasn't happening in their system. And also, with hydration, it decreases vaso-occlusive crisis, which leads to sickling. So that's my explanation for the increased levels of zinc in the sickle cell patient.
Hydration levels could compare outpatients, and so that's just thank you very much.
Yes, it's just a comment. The portion where you were discussing your results and you were comparing them to various studies, you just say this study, that study, and of course you show us something about it, but we don't know what that study is. So you finished with about 5 minutes more to go. You could have spent a little time telling us what those studies are saying and how it conflicts with your results or how it supports your results. Okay.
Thank you. I think it was a good presentation. My input is, I think something could have been a confounder in your research, because the outpatient, I don't know whether they were put on hydroxyurea and maybe folic acid. Did you find out that because it would really affect the outcome of the research? Thank you.
The outpatients were on folic acid. All of them are on folic acid. But the hydroxyurea, they don't request it for them.
Thank you very much. Let's give a round of applause. Second presentation is from Dr. Isaac Ochre of Department of Surgery, and he's going to talk of surgical management of traumatic diaphragmatic rupture, 10-year experience at Confanochi Teaching Hospital.
Thank you very much. I must say that good afternoon to my moderators, Prof. and Doctor, and to state first of all that I'm a surgeon, and surgeons are simple-minded people, and though on the background of brain tissue. So I'm not the scientist who just spoke. So presentation is very simple. So our first paper is on vascular access for hemodialysis in Ghana, a single center experience. And our experience here is the Confanochi experience. I don't have any disclosures. The only thing that I'm saying, I'm a surgeon, and I'm a simple-minded person. So I'm going to go through introduction, method, results, conclusion, and then some references. We all know that chronic kidney disease and end-stage renal disease have become an issue in Ghana and over the world. Thankfully, access to treatment has improved, especially when it comes to renal replacement therapy in the first form of hemodialysis. To the extent that even in children now, we have a opportunity in Kumasi here and are going a special type of dialysis called the peritoneal dialysis. But so hemodialysis as a renal replacement therapy for patient either on CKD, chronic kidney disease, or end-stage renal disease is available. But what's important is that to have access for hemodialysis, we need something called vascular access. You need to have a stable vascular access before you can be put on the machine to have the dialysis. And there are various kinds of vascular access for hemodialysis. So we need to study to find out the types or the kinds of accesses that are available in Kumasi here, in the various in our unit at the Community Teaching Hospital. So basically, we have about what we call two main types of vascular access. We have what we call the temporal vascular access and the permanent vascular access. If the patient comes in an emergency, you usually give them a catheter which is inserted one of the big veins in the body, especially the one on the neck or the thigh, usually on the thigh in emergency situation for hemodialysis. That emergency vascular access, usually which is done on the thigh at the groin of the patient, is supposed to stay maximum 2 weeks to about 1 month, especially in this emergency situation. Then later, another catheter can be inserted, another big vein on the neck or the chest. That one can stay more than 1 year, sometimes 3 years, which is called a permanent catheter. But the best option, or the best options are two, which are the chronic type, which the permanent catheter is one, but the two main types we need is what we call a arteriovenous fistula, where ideally a connection is created between an artery and a vein on the upper limb, usually. And the upper limb can be done on the thigh as well, but on the upper limb, which is created for the patient to use. And the creation we call the AV fistula, is very important. Ideally, that AV fistula should be created based on a particular renal function stage on a patient who is being monitored by the physician. So the patient doesn't come on a catheter. So ideally, any patient who is a risk for dialysis at a particular function test called the EGFR, a particular value, that patient is supposed to be referred to the vascular surgeon to create an AV fistula with anticipation that in months, 3 months or 6 months' time, that patient may need hemodialysis, and therefore, by that time, that fistula would have matured for the patient to have that. But it doesn't happen very often in Kumasi or in Ghana, we put it that way. Here, the patient really comes in an emergency, and therefore they are given a rubber or a catheter, artificial catheter, at the groin, and then when the patient steps, they come later for another catheter on the neck. Then later they refer to the vascular surgeon to have the creation of the fistula. So it's a reverse. To say that the best vascular access for hemodialysis should be what we call the native AV fistula. But you find out what is happening in our system, which types are available. So we have 3 main types here. The synthetic, where we put an artificial graft between a vein and artery on the arm or the thigh, or you have just a catheter on the neck, and the creation of just connection between the native artery and vein. So we have AV fistula, synthetic AV graft, and then the central venous catheter as the options for vascular access for hemodialysis. But I must say that the best should be the AV fistula. That's the recommendation for the international community of kidney associations, followed by the graft before this one. So our objective was to conduct retrospective analysis, just retrospective analysis of the kinds of vascular access currently available for patients on dialysis at the community hospital, the renal unit. So we studied from October 2016 to October 2019, 3-year period, considering all the patients at the renal clinic of the community hospital. So patients on dialysis within periods, they were included. Any patient who had incomplete data was excluded, and patients at the clinic who had not started dialysis were also excluded. So in total, we had about 80 patients from the study period, and we took into consideration demographics of age, geographic rotation, whether they are living in rural or they are in urban cities, the marital status, educational level, and occupation. Then for the clinical data, we took consideration of the type and stage of renal disease, the duration of hemodialysis the patient had been on, the type of vascular access, and the site of vascular access. Of course, we obtained ethical approval from the Ethics Committee of Community Teaching Hospital, and we analyzed using SPSS. Just a basic descriptive study, so no much difference, just cross sociodemographic clinical variables present as percentages and frequencies, cross tabulation for calculated data, and a chi-square for associates, especially between age, gender, marital status, education, employment, location, duration of dialysis, and the dependent variable, which is the vascular access type. So for the year group, we had majority between 30 to 60 years and above. To let you know that if you look at it critically, you can see that from 40 going, there's an issue there. The age, as your age increases from here, your risk for developing any kidney disease increases. Actually, there was a study, I didn't put it on, that Perita Eta found out that the mean age for renal diseases in Kumasi here was 45, average 45 years. And it was relatively higher in males than in females. And the details say the same thing. And that's a message to our men here, that should be careful when you are around 40 going, be careful with your life, because you have potential to have increased risks for renal diseases. So this is the agenda for the age group for our patients, and the gender as well. Increased incidence in males as compared to females. And obviously, it's going to be increased marital people. The expectation that's from 40 years and above, most men will have married. And then if, or they're in a relationship, and therefore the incidence was higher in marital status patients as compared to singles. Then, if you came to educational level, you could realize that primary education was competing with tertiary education as the risk factors as compared to more formal education. It was very low. I don't understand why it should be that low. Maybe they don't care about anything, so, but primary education and then tertiary education were the leaders in terms of the education level. Employment level 2, you could see that traders were leading. And maybe to make sense there, traders were leading. The same study was found by Preta too, that traders, so those doing business were leading. I'm sure probably people will take their goods, they will not pay back, a lot of stress issues are there in terms of businesses. And as their stress level increases, the postulation that maybe increase hypertension rate and therefore put the kidneys at risk. And then we also realized that most of the patients, surprisingly, had a rural setting as compared to urban people. And that's difficult to explain from there. So we came to the vascular access as companionship. Remember, I said the best should be the AV fistula, followed by the AV graft, before the simple catheter. That is standard. But let's see what we have here. We realized that for the vascular access, about 43 or 44% were having temporal vascular access, not permanent, temporal. And those temporal ideas should stay less than 3 months. It should be out. And AV fistula was about 22 of them, or 28%. And the Tanner, which is is a catheter, but it's a permanent catheter, was about 19%. So temporal vascular access was highest here in our finding in the vascular access. Then for the venous type, the type of vein in the body used, we found out that most of them were from the internal jugular vein. That's the big vein on the neck, that's the internal jugular vein. This is the commonest vein used for most accesses all over the world, followed by the subclavian vein, followed by the femoral vein, the ones on the thigh, which is used mainly at emergency situation. The vein, the big vein on the thigh, on the groin, the femoral vein, which is for the emergency situation. When the patient comes in emergency situation, is in pulmonary edema, they have to do vascular hemodialysis, emergency dialysis. That's the vein they usually access. So therefore, the second vascular vein they used was the femoral vein, but the highest was the internal jugular, the vein on the neck, both for the temporal access and for the permanent access. The side of the neck, we also see that the right was the commonest. The reason that why we usually use the right internal jugular is that the right internal jugular, that big vein on the neck, runs directly into what they call the superior vena cava and runs directly into the heart. For us, so there's a short distance from the internal jugular to get into the superior vena cava into the heart, as compared to the left internal jugular, which has to cross all over and come here. So it's a longer length, and the curvature sometimes affect the catheter, and therefore the best internal jugular vein to use was one on the right. So it's not strange we had the highest number on the right, about 49 or 61%, and about 30% on the left as the vein of the site of access. Then for the duration of access, because of the 80 patients, how many were, we realized that about 34 of them have been on dialysis for just less than 3 months. And for 3 months to 6 months, we had 11 patients. And for those above 6 months to 12 months, we had 12 patients. And we have those above 12 months, more than 1 year, E23, form about 29% of the patients. So you could see that majority were between less than 3 months and then more than 1 year. Then looking at our diagnosis, this acute kidney injury, this acute kidney injury stroke, CKD, acute kidney, chronic kidney disease, and then end-stage renal disease. You could see that only 4 of the patients out of the 80 were diagnosed acute kidney injury. 17 had acute and chronic, and then 22 of them had end-stage, that's stage 5 chronic kidney disease. For the duration, as I said, if you look at, if you actually compare, this is temporal vascular access, the vascular access type. This is fistula. This is the long-term catheter. That is standard vascular catheter. This is temporal. This is tunnel. It stays longer. and this is the AV fistula. You could read those patients who had acute kidney injury, all of them had temporal catheter. None of them had this. Other AV fistula, because they came in emergency. So obviously, femoral access, maybe internal jugular, for dialysis, several of the patients. So, but they are just calm. They are just on temporal catheter. Then if you move to the chronic kidney disease or acute on chronic, you see 17 of them were on temporal catheter. Nobody had AV fistula, and only 6 had tunnel catheter. But as you increase to end-stage disease, 22 were having tunnel catheter, temporal catheter, 15 had AV fistula, and then 16 had tunnel catheter. So as the patient comes in the end stage, they are more likely to need chronic hemodialysis, and therefore they were likely to have, after the temporal insertion, either a fistula or a tunnel catheter to have continuous consistent hemodialysis. Then if you cut the duration in relation to the type of vascular access, those who are less than 3 months, same thing. 25 of them had temporal vascular access, 0 AV fistula, and only 4 had tunnel catheter. So those who are still 3 to 6 months, 8 had temporal catheter, 1 had AV fistula, and 3 had tunnel catheter. And for those 6 months to 12 months, 7 tunnel, then AV fistula 1, then 6 tunnel. You could see that as you age, as the patient stays longer on hemodialysis, then the patients have the chance, opportunity to have either AV fistula or the tunnel, a longer catheter can be inserted. And obviously, when the patient is on dialysis for more than 1 year, only 3 decreases had a temporal catheter. They will need a chronic and more stable catheter or a source of vascular, which is either the tunnel or the AV fistula. And you see, majority of them were having AV fistula. So if the patient stays longer on hemodialysis, the most likely the nephrologist or the physician will refer her or him to the vascular surgeon for they have AV creation. But if they stay longer, then either the person will die before the 6 months, then he will be on temporal catheter or tunnel line until he comes more than that, stays more than 1 year. So in conclusion, I want to say that the leading vascular for hemodialysis is the temporal type in Kumasi, which is contained in the worldwide recommendation of AV fistula. And the commonest venous access used for rural dwellers is temporal venous access, constitute about 76.9%. Majority of the urban dwellers use AV fistula. The reason being that they have the opportunity to be referred to the vascular surgeon. The vascular surgeon is in town, is in the urban center, and therefore have the opportunity. The poor soul in the village may not have the opportunity to have both in terms of cost and the human resource or the doctor to deal with it. Therefore, the rural dwellers usually have a temporal vascular access as compared to the urban dwellers who may have the opportunity to be seen and reviewed by the vascular surgeon to have the creation for AV fistula for them. The dominant vein used was internal jugular, which is consistent with international recommendations, about 80.5%. And it was realized straight away that patients on longer duration of dialysis are more likely to have AV fistula. So our recommendation is that early referral of chronic kidney disease and end-stage patient to vascular surgeon for AV creation should be encouraged and probably to be fair to rural dwellers. Treatment and management of CKD, ECA, ESRD should be included in the nation's national health insurance to encourage those patients who can afford to have access to the doctors and the specialized to handle for them. Thank you very much.
Looking for discussion. Any question, comment? Put the hand up there.
Thank you. Thank you for your wonderful presentation, Mr. Speaker. My name is Gustav Komlagan. In your presentation, you said that the kidney disease is more common in men than women, and also more common in people from the age of 40 going. So I want to know what accounts for this. What are you doing wrong that we men are experiencing more kidney disease than expected?
Okay, thank you, Senior. Hope for me, our professor of nephrology is around.
Just add that as one.
Yeah, thank you very much. I'm going to say that my professor of nephrology is around, Jose Egan is around, and leading the nephrologist community also is around, Dr. Perita Ochi is also around. They'll make a comment if possible. Okay. Yeah. Okay. So, first of all, we call something cardiovascular risk factors. Cardiovascular risk factors in life. All cardiovascular diseases. When you say cardiovascular diseases, we mean diseases of the heart and the vessels. So if you have diabetes, you have cardiovascular disease. If you have hypertension, you have cardiovascular disease. If you have peripheral disease, you have stroke. If you have myocardial infarction, heart attack, you have cardiovascular disease. All of them, they have common risk factors. Risk factors for stroke, risk factors for heart attack or myocardial or coronary disease. And then kidney disease is also a cardiovascular disease. So all of them, they have common risk factors. The risk factors divided into two. Because of the modified risk factors, the one we can do something about it, and what we call non-modified risk, the one we can do it about it. For example, being a male, yes, nowadays it's possible to change your sex, but being a male is a risk factor for cardiovascular disease. That's number one. So being a male is an established risk factor for having cardiovascular disease, which includes kidney disease. Having a family member with the cardiovascular disease is a risk factor. You can't change your family, you can't do anything about it. But and then the race, there's a small race about the black race also being a race. So that's, put that one aside. But the things we call the modified, the ones we can do something about them. The first one is diabetes. The second is hypertension. The third is dyslipidemia. I call them the GBC molecules. G being glucose, B being blood pressure, and C being cholesterol, which is your lipids. So the risk factors which something can do, which can produce cardiovascular disease, including kidney disease, your blood pressure, your hypertension, and your glucose. You see, those can do something about that. So those are the risk factors. So if you are hypertensive and you are diabetic, your risk factor for kidney disease increases. If you are a male, the risk factor increases. If you are a family member with a kidney disease or diabetes hypertension, your risk increases. So that's what you have to know. If you know that, for example, you know your parents were hypertensive or diabetic, I think as soon as you've reached 35, 40 years, you start monitoring your life. Check your BP, check your sugar. As soon as they come up, you deal with them when they are at the primary school level. Than to wait for them to go to university level BPs and sugars, they become complicated. So the risk factors are established. You just have to know them and prevent them. That's what I want to say. I don't know whether Peter wants to say something. Okay, Peter will say something, but let me say the first is that what they realized that before age 50, the females were being protected from cardiovascular disease from their estrogen hormone until they lose the estrogen, and then some of their protection decreases. That's for the females. So you realize that before 50 years, the males were leading in terms of having increased risk, but after 50, the incidence decrease. The females become more riskier than the males. But for the male one, it's more genetic makeup. It's more genetic makeup. And maybe, I don't know whether there's a small thing. And so why the males? That one, we were trying to postulate. In fact, that study, I wanted to put it, the last study, pastors, surprisingly, pastors were the least at risk. Pastors. Number two, pastors and Muslims. Muslims and pastors were the least. Christians were on top, and businessmen traders were on top. The assumption is that, or the postulation is that the business people, the traders, like a typical mothers in town, you go and you give your trader to somebody to sell for you, you come for the money, there's issue, the money is lost, someone will travel for to buy things for outside on the border, they can lose things. So many things happen in the business. It's very risky, and I think the stress of it, what they predispose them to having stress-induced hypertension, and as well as hypertension, then the risk of kidney disease increases. And also that stress also induces them to have diabetes, and the two combined, it increases their risk for renal disease.
Thank you very much. That's good. It's a very good presentation. And for me, it tells us that the progress in the health delivery that we are doing, vascular surgeons in town, and now we have fistulas and the rest, beyond what formerly we have been using, the catheters and the rest. So, well done. You've done very well. That's what I want to say. The second thing is that just a soft one. The terminology now is moving from ESRD to EK. Now, we don't want to use end-stage kidney disease instead of renal. So take note of that. And you're going to refer to Pedita to respond to something. Probably let us know that is your wife. That's also important. That your wife is also a nephrologist who leads the Kopanoche head. But on a more serious note, it's a good data you have presented, but I thought you could have also told us the factors that determine which vascular access you use. The factors, okay, whether it's because of money or what, and probably in those that we have done, if there were also some complications that actually develop, because somebody can be in a tunnel catheter and then develop complications, and then necessarily you need to move the person to a next line. If you have a data on that, you can probably let us.
Thank you, Prof. Yeah. And inspiration to us since we returned to Kumasi. I must say that this is just a retrospective data that we collected, we analyzed. We actually are studying our vascular AV fistula alone. Since I've been in Kumasi for the past a little over 5 years, we've done more than 70 AV fistulas. I've done revisions, some will get complications, probably say aneurysm, some have ruptured. Some AV graft they brought from UK, they did in UK, ruptured in Ghana, I have to repair. So the whole part, which is more surgical for me, that we will publish very soon about our experience of just AV fistula in Kumasi. But for what happens for the vascular access, because most of your physicians, you don't present a patient ideally to the vascular surgery before dialysis, they come and they've punctured most of the veins. The veins are poor. Even when you do venous mapping by the ultrasound, the veins are so poor. So because of that, they come in emergency, and therefore they give them most of the time femoral catheter that approach the Kofanache, and the patient stabilizes. They give them the neck one, then later the patient stabilizes before they refer to the vascular, which is a total reverse in the standard evidence-based practice. So the encouragement that I don't know whether physicians are here, but if a physician, I have a patient who is diabetic hypertension, know that he is at risk for renal disease, please monitor your EGFR as early as possible. As far as it is going below 30, Prof says 30, ideally, it's going below 30 EGFR, less than 30, refer to a vascular surgeon, and so we can put, at that time, the veins no have tempered with a lot, and therefore they will be patent enough for it to create a very good fistula, AV fistula, so that it can have to be used when it actually is needed. We have few cases. Just about 3 weeks ago, I did 2 cases who are just new they yet to start dialysis, and the smart physician referred to us to put them down, create it before they can use it. So that's the challenge we're having now. But ideally, we should have the fistula created before the patient comes. But if you have an emergency, that is femoral before neck, before fistula, with the reverse. Thank you very much.
Okay, thank you, Dr. Oche, for the presentation. It's very enlightening. You did mention that the access, the commonest, was the internal jugular vein. And you went on to say that 49% of the cases that you saw had the right internal jugular vein. You had earlier mentioned, you had shown us the anatomy, and you told us that the right is easy because it's direct to the superior vena cava. Now, you said 31% were on the left. I'm surprised about that figure. Was it the first time that they were having it, or probably they had the right, which didn't work, and therefore they put it on the left? Because I teach my residents to always go for the right, because the left is tortuous. You know, you get the superior vena cava. So I want to know whether these were people who had the first access on the left, or they had it on the right, and because the right was not working, it was shifted to the left. I want to know this from your research. Did you find out whether this 31% was the first time they were putting it there, or probably they had the right, it was not functioning well, and therefore had to be changed to the left?
Thank you, Prof. And that's a very smart question. And I'm sure Peter will have that information. But I pointed out, all of them, none of them were first attempt. All of them, most of them were attempted right, which has blocked or has complicated. And therefore, the patient still need access. And the patient does not have the fistula, so you have to go to the left. Several times when they call me to the dialysis unit, and I have to put the emergency even left subclavian instead of the internal jugular, so that you do subclavian before the right. So most of them were first attended on the right, other complicated, then go to the left. There's only one picture I remember. It was how do you call it? Pompo. I don't know Pompo's English name for Pompo. Yeah, where the anatomy on the right, it was scoliosis, and therefore the neck was difficult on the right. So you had to put that on the left. So most of them were complicated right before we entered the left ground. So basically, that was the reason. I don't know whether I've completed the question. Yeah.
Thank you very much for your presentation. I've learned a lot from it. My concern has to do with the stress factor. Looking at your demographics, you realize that those who were married had a high incidence of it, and then traders, basically the demographic factors that has to deal with a lot of stress factors had a high incidence of it. I'm wondering, was there any psychological intervention for these people, even whilst on dialysis? Or if not, after your analysis, have we made that recommendation to the appropriate bodies that if someone is at risk, the person starts psychotherapy and have that kind of psychological intervention for their stresses before it even escalates into that condition?
Yeah,
thank you.
Thank you very much. I'll let Peter come, but I'll state that there's a paper published by one of Dr. Philip Oche's colleagues in Kolebu about the psychiatric issues in patients on dialysis. But maybe you should make note about the comment about the state of your patient.
Thank you very much. Normally we collaborate with the psychiatry unit to refer most of our patients to see them. And even sometime before we start you on dialysis, we do psychological counseling as well. But I just want to make a small comment on the factors influencing the choice. We realize that the rural areas, it's not like the physician will not let the patient go for the AV fistula. Whereas people coming from the rural areas were higher than the urban people. And what we've seen is that the rural areas will come in emergency, and therefore that will influence the type of access Those in town will come, we will see them at the OPD, we monitor them, and therefore we can refer them early for the AV fistula. And we also realize that those with the acute kidney injury, yes, if you have acute kidney disease, you don't need the permanent access. All you need is the temporary one, and therefore that's how come the data showed 0 for the AV fistula for the AK either we saw, and then 0 for the graft. They don't need that permanent access. Thank you.
Okay. I think probably to make a comment on whether it's okay. It's okay.
Any other question? I don't think so. But you are the same presenter for the next. Okay. Please, two announcements before we move on to the next presentation. There is evaluation form going round. Please kindly fill it and hand it over to the ushers. And then the next A3 presentation will be done here. So please take note. Those of you who want to attend the A3 session is here. Thank you.
So I'm sorry, I mean, this is a surgical thing, but I hope you can understand, have some information about this thing here. It's more surgical thing. So we are looking at the surgical management of traumatic diaphragmatic rupture, 10 years experience community teaching hospital. Now, we all know that the diaphragm, no disclosures here once again, I said that it's a surgeon, it's a simple-minded person. We go through the same introduction, method, results, conclusion, and the references. We know that the diaphragm is the partition between the chest cavity and the abdomen. The wall that separates your chest, or what you call it, thoracic cavity, and your abdomen is called the diaphragm. And God was smart to separate the two compartments for very good reasons, because they are very important and very dangerous organs in the chest, which should not communicate with the organs in the abdomen. And there are also things in the abdomen which should never appear in the chest. One of them is the F objects. Feces should never appear in the chest. If you appear in the chest, you are dead and gone. So God was smart to separate the chest cavity from the abdomen by creating a partition called a diaphragm. So ideally, there are only some small holes or channels in the diaphragm that allow some object to continue to flow from the chest into the abdomen, especially the one we eat through it. You know, the esophagus goes through the neck, the chest, and then it will enter the abdomen through a hole in the diaphragm called the esophageal hiatus. Same thing, the big vessel that supplies the abdomen in your lower limb, which is called the thoracic aorta, will also pass through the diaphragm through a perforation, a hole called the aortic hiatus, and then enter the abdomen to become abdominal aorta. So that's our diaphragm. Nice muscular structure that will separate your chest organs from your abdominal organs. What happens is sometimes there can be an injury such that this fine structure here, which is very intact, can be damaged, and there can be holes in it, or there can be ruptures in it, or there can be lacerations. When it happens that way, then organs in the abdomen can go into the chest. And we call it herniation of abdominal organs into the chest. Reason being that the pressure in the chest usually is negative, while the pressure in the abdomen is positive. And therefore, if there's an injury to the diaphragm, said that there's a hole somewhere, then organs will be pushed or sucked into the chest. And we realize that traumatic diaphragmatic rupture can occur either in a blunt chest injury or in a penetrating. When we say penetrating injuries, we are talking about injuries that are due to either a stab injury with a knife or a gunshot or any impairment structure that can hit the chest and cause a damage. Or any blunt injury to the chest. Someone give you a blow, you are falling down, you fell from a tree, or road traffic accident, you can have an injury to the chest. So you have both either a blunt chest injury or chest trauma or penetrating injury to the chest. Each of them can result in a rupture or a damage or a laceration to the diaphragm. That can, plus or minus, lead to herniation or movement of some of the contents of the abdomen into the chest. And there are consequences of that. And realize that it has also, as usual, male predilection, i.e., more common in males. You must accept that you are the lead in everything. You are leading everything, so you lead in most of the things as well, disease as well. So it's very common in males as well. It's very common in the third and fourth days of life. Incidences for diaphragmatic injury in blunt and penetrating is usually very less common in blunt injuries, reported by 0.8 to 7%, but increase in penetrating in chest injuries, almost like 15%. But interestingly, diagnosis is usually delayed because it's very difficult to diagnose it, very, very difficult. And sometimes it's only diagnosed when the patient undergoes surgery in the abdomen, laparotomy, and the surgeon accidentally finds it. He was going for other injuries, and then incidentally he inspected the diaphragm and found that there was a damage in this. So 6% are missed with multiple injuries, and when the patient has gone to laparotomy for other surgery, then it's diagnosed. Adeboye in Nigeria, who studied 177 patients with trauma, found about 6.5% prevalence among for diaphragmatic rupture. Despite our improvement on how the body can be imaged in terms of chest X-ray, chest CT scan, MRI, we have improved in our diagnosis still, but still, even with that, we also have a challenge of diagnosing diaphragmatic rupture, still delayed. So, and there's also, even when it's diagnosed, how it is managed surgically. There's controversy still between the thoracic surgeon and the general surgeon in terms of the best approach to repair a damaged diaphragmatic fracture or damaged diaphragm, and even the surgical technique, how it is repaired, how it's approached, whether it's repaired through the chest or it's repaired through the abdomen, and how to repair it. There's a controversy amongst them. There's issue between we and the general surgeons all the time. Currently, we don't have any study on it in Ghana. There's only 2 studies that we published in 2019 and 2020, just the COVID period. And that's why we decided to present this one. There's one we published in Pan-African Medical Journal. When we first published our first experience, 2 cases of traumatic rupture on the right side. Usually, it is not very common to have rupture of the diaphragm. This is the right diaphragm. This is the left diaphragm, or the right hemidiaphragm, the left hemidiaphragm. The liver is on the right side of your abdomen. The liver is the largest organ after the skin. And therefore, it's very difficult, this right hemidiaphragm is protected by the liver. It's very difficult for the right hemidiaphragm to be damaged. It will take very severe injury before the right hemidiaphragm can be damaged because it's being protected by the shock-absorbing liver. So for the first time, we had experience of 2 rare cases of right diaphragmatic rupture, which is very strange. In my training for 10 years, I never came across a right hemidiaphragm rupture. And therefore, when we saw it, and luckily for us, the 2 cases, one was a blunt chest injury, the other one was a penetrating chest injury. Very fine, 2 different cases. So we published them and we sent the Pan-African Medical Journal and they purchased for us. So in 2019, we published our first experience of the 2 cases of rare right hemidiaphragm rupture. Then last year, 2020, we also shared our experience, another rare cases of diaphragm rupture of the left with herniation of the stomach, which have been perforated, causing what we call severe meniscitis. And for us, for we characterize surgery, we never want to have infection in the chest.
Hello? Yeah, I'm sorry. For us, we never want to have infections or inflammation in the chest, because inflammation in the chest, what we call mediastinitis, is never forgiven, very unforgiving. If you have mediastinitis, you are dead. If I choose between what we call infection in the abdomen called peritonitis, and then like ruptured appendicitis, and the choose between peritonitis and mediastinitis, you will choose peritonitis. Because the abdomen can expand and expand. Even people, I'll say they get pregnant. But if you get, the chest is fixed by the bones, the sternum and the ribs. There's no space for expansion. So if you get inflammation in the chest and it expands, you're going to crash the heart, crash the lung and kill you. So mediastinitis is very feared. So we've got these two patients, surprisingly, two patients with diaphragm rupture on the left side with herniation of the stomach, into half of it into the chest, and perforation with very severe mediastinitis, and they were dying. So when we were lucky to operate on them and they survived, there's a population. So we published our experience too just last year. So these are two main experiences in Ghana now as far as diaphragm rupture is concerned. So we decided then to say, okay, then let's see what has happened for the past 10 years at the Community Teaching Hospital. What has happened in terms of the surgical management of diaphragmatic rupture. The interesting thing is that I returned in 2015, later part of 2014, but actively 2015. So the last 5 years I've been here, I've been operating most of the patients who need repair for diaphragmatic rupture. Before the 5 years, the assumption is that the general surgeons were repairing. Only 2 occasions when I was away, I came for vacation, and I repaired 2 cases, 2 tracheotomy. In principle, so we decided to evaluate our 10-year experience in terms of our surgical approach, whether it is through abdomen or through the chest, the technique, how we repair it, and the general outcome of the patients. So it was a study of at the Community Teaching Hospital from January 2010 to June 2020. We look at the demographics of the patient, the cause of the rupture, the type of surgical approach, the type of anesthesia used, intraoperative findings, and then you retrieve them from the theater records of the patient. You got ethical approval from the ethics committee of the Community Hospital, and we use SPSS22 to analyze data. So if you look at the demographics carefully, you realize that, and don't beat me, it's still the male issue. The male to the female issue is about 5:1. The expectation is that the males, we are the active, we are going around, you are the work. You know, if you look at the occupation, trader 6, student 6, civil servant 3, artisan 8, farmer 7, unemployed 5. So the non kind of civil work people are a lot, and therefore they are very engaging, and therefore trauma in terms of traveling, in terms of fights, in terms of assault is increasing them, and therefore they are more predisposed to having diaphragmatic rupture. So the female to male ratio was 5:1, and the total number was 35 cases. And here, 12 people were married, singles were 19, divorced 3, and divorcee 1. The picture on the right is one of the cases we saw as when we reported in our right diaphragmatic rupture. If you can see well, you can see clearly that this is the edge of the diaphragm. This is the liver. What you see there is the liver. We have opened the chest. We haven't opened the abdomen. We have opened the chest. You can't open the chest and see the liver. The liver is supposed to be the abdomen. It should be the chest. But there's a rupture of the diaphragm, the edge there, and the liver is showing. What do we repair? And when we repair nicely, you see the lung there, and this is the diaphragm be repaired nicely, one of the cases we did. So looking at the cause of the diaphragmatic rupture, we saw that 18 of them, out of 35, was due to blunt chest injury. Whereas penetrating injury were 17. Penetrating injury were basically stab wounds with a knife, usually it was a knife, or permanent injury, or gunshot wounds. Unlucky for us, most Ghanaians or blacks are right-sided, and the diaphragm is on the left side. So if the person faces and shoots you, it's more likely to go to the right side. So either he will kill you because the heart is there, or he will damage the diaphragm. It's unfortunate. So you can lose patient because of the direction. And you see some of the impairment injuries. You see a knife at the back there. This one too, a dagger. They call it a dagger. There's about 3 pieces of it. There's a, it's like there's a knife. There's so many things inside there. that we have to repair. And here to the same thing, this was one of the cases on the left side. You see this is the spleen, this is the omentum, this is the liver, this is the edge of the diaphragm. They are all in the chest. Impossible. But it's a bad, very long diaphragmatic rupture. Very bad injury. Formally, all these patients will die anyway. They will die. They will die. So by being able to approach it, repair it, push everything back into the abdomen, and then repair the diaphragm and keep them alive. So if you look at the type of injury, impairment injury, and I would say the impairment basically knives, metals, and then we had gunshots, we had the stab injury, also part of it. Impairment means that when the patient stab the person and the object is in situ, they will say it's impairment. But when you stab and you remove it, it becomes a stab injury, a difference. Okay, and then we have the road traffic accident. So for the sides, we have 91% be on the left side of the diaphragm, only 9% on the right, or therefore about 4 on the right side. And then for the approach to the repair, either to the abdomen or to the chest, you saw that to the abdomen repair was 49% and to the chest was 51%. That means that the characteristic did that. And then when you open the chest, the type of organ which has herniated into the chest, the commonest organ that will go to the chest, especially on the left side, or the stomach and the omentum, followed by stomach, omentum, the colon, and the rest like that. So these are the herniated organs which we found in the chest when there was an injury, especially on the left side. And then for the repair, the cardiothoracic surgeon repaired most of them. That's why he repaired the 51%. And the general surgeon repair. And this happened before the coming of the cardiothoracic surgeon. The first 5 years, it's a 10-year period. The first 5 years, most of them were repaired by the general surgeons, while the last 5 years were repaired by the cardiothoracic surgeon. And so in conclusion, we said the diagnosis of diaphragmatic rupture can be a common occurrence in thoracoabdominal injuries, whether blunt or penetrating. Penetrating injury is the leading mechanism of chest trauma, the leading cause of the injury being road traffic accident. One thing I fear in my life, road traffic accident. It commonly involves the left hemidiaphragm. Surgery is the treatment of choice and is repaired via laparotomy or thoracotomy based on the presence or the absence of concomitant abdominal injury or in the site of the trauma or the presence or absence of a cardiothoracic surgeon. And some of the intraoperative pictures we had, some of the patients we had, we repaired them nicely and they are alive. This is our unit, our new unit we established about 5 years ago, the cardiothoracic unit in Community Teaching Hospital. We are not doing bad. Enough of our references. Thank you very much.
All right, please let's give Doc another round of applause. Yeah. We thank you for the crash course session. Any questions, contributions? Yes.
Thank you, Sergeant. I think it was insightful. I want to ask that when patients come in with chest injury, usually in the peripheries, there might not be surgeons or only physicians will be around. So I want to ask whether when we do thoracotomy with chest tube insertion and then we refer them, does it help? Thank you.
Okay. Thank you very much. Actually, I have a poster that's talking about our experience of the management of chest trauma. And if you look at the poster, I say that in the management of chest trauma, most chest trauma patients can be managed conservatively without surgery. About 80 to 85% of all chest trauma injuries, whether blunt or penetrating, are managed without surgery. Only about 10 to 15% will need surgery. And I hold the poster there. So, if the only procedure we will do for patients who may need any procedure at all for chest trauma will be the passage of a chest tube. When there's a collection, whether air or blood or both, what they call pneumothorax or hemothorax or hemopneumothorax, that we pass to drain it. Most of them, just by simple oxygen, adequate analgesia, antibiotic and chest tube, they'll be okay. That is why when I return, I'm insisting that every doctor should know how to pass a chest tube. Because if you know, every doctor knows how to pass chest tube, we will save 25% of all patients in trauma. Because chest trauma contributes 25% of all chest trauma, plus 25% mortality. And the only thing you may do is just to pass a chest tube. And so the chest tube will be all that the patient needs to save him or her, like what they call tension motoras. You have to pass chest tube, the patient dies. So now in Covenantry, every house officer does some weeks in chest thoracic to learn how to pass chest tube. So that at least, as I was saying, you put a chest tube, then you can refer then the patient if there's any feedback. Assuming the patient had traumatic rupture from the chest trauma. And if you pass the chest tube, assumingly, you will save the patient down there. Otherwise, you may have died from hemothorax or pneumothorax. So yes, you're right. The minimum possible procedure you may have to do to save a patient at the periphery of the chest trauma with the collection is to pass the chest tube. And every doctor now, we are trying, Kumasi, to make sure that we show every house officer leaves Kumasi, he knows how to pass the chest tube, at least. To see the patient, then can band the patient and refer to Kolebu or Kumasi for the further care.
Thank you very much for the presentation, Dr. Acho. I'm not a surgeon. Maybe that is why I'm asking. If it happens that after fixing, the patient is okay, he goes home, and then happens to have another injury at almost the same place, what are the chances that you can fix it again, and what is the survival rate?
Okay, so we can enter the chest anytime, any day. There's an asylum in India that the former prime minister had what they call cabbage, because something called bypass operation on the chest. Open heart surgery. We Africans, we are entitled to only one option, but we can't pay for it. He has had 7 open heart surgeries. That be the chest has been opened 7 times. Anytime you open the chest, it can take you 2 hours before you can open the chest again. But we open it. So the point is that if there's which week, you're right, you can't predict tomorrow. But whatever it is, if you happen to have your place, Kumasi or Kolebu cardio, yes, independent of the years or time it happened, or how many times the chest will be open, you can still reopen it. Yeah, thank you.
Thank you. I could see this is a major surgery. So I want to know how long does it take the patient to recover fully from such operation? And also, after he recovered, has he stay or live with some condition? He's recovered, so stopped 100%. Thank you.
Thank you very much. Yes, first of all, most of our surgeries, in average of, if we're very lucky, average of 4 to 6 hours. Most of our cardiothoracic surgeries, if we're lucky, it's an average of 4 to 6 hours. If we're not lucky, it's only 20, 13 hours. It can be the whole day. So usually the duration of the surgery is very long, and unlucky for us in Africa, it's a whole, you need intensive care, very sophisticated, you need intensive care. For now, when I came, I was alone, so when I operate, I have to sleep in the ICU, take care of the patient, myself, with assistance of my nurses, and sometimes anesthetists. So it's not been easy. But you need care. It should be intensivist sitting down. Most of the time, they'll be in the ICU. We cannot operate and send the patient to the ward. No. Every patient from theater to the intensive care unit, they may stay a day or 2. Then they'll be extubated. The tube from their airway or respiratory will be removed. And then maximum 5 to 7 days, they'll be discharged. And they're restored forever. Except that if you open the chest to the sternum, we call it sternotomy. If you do tracheotomy by the side, fine. Then we don't break the ribs, so that's fine. We only part it to do whatever inside there. But here we have to cut through the bone here, the sternum, sternotomy. And if we cut the bone, we repair with a wire, and we need 90 days to get the pre-surgery state strength of the sternum. So if the patient had operation to the sternum, he has to stay away for heavy lifting and things for the next 3 months. to allow the sternum to heal. That's the only thing. Otherwise, by the side, after 1 week, 2 weeks, a patient can do what you want to do. But if it's sternum, you need rehabilitation for some time. So you have to avoid some heavily other things before, after 3 months, then you have the strength for the sternum to do the normal. So you avoid lifting, contact sport and things, any heavy activity until the bone is fully healed. Otherwise, you are restored to normalcy. Then it should, except that you have a scar. That's all.
Thank you very much for that wonderful presentation. Please, I want to know the other clinical manifestations that the patient will exhibit in case there's something happening like the diaphragmatic problem that you were talking about. Other symptoms that the patient will manifest for you to know that this is what has gone wrong. Because there was an instance, a situation where a patient went to farm and a tree fell on his back and was rushed to the hospital. On admission, this patient was not exhibiting any sign that something had gone wrong within him. But then the doctor on the following morning, that was the second day, assessing the patient, said he could hear bowel sound in the chest.
Yeah.
And so later they did the x-ray and saw that there has been bowels, some of the bowels have moved to the diaphragm, through the diaphragm to the chest or wall. So they decided to do surgery. In fact, I followed up. I wanted to see how the diaphragm is going to be opened and that kind of thing. So the doctor opened, and I saw that it was a sharp cut.
Yeah.
It's like a knife that they have used to, cut through the diaphragm. He removed he brought the bowels back, and then sutured it. But why I'm trying to what I want to know is that this very patient was not exhibiting any respiratory distress, that kind of thing. There was nothing like that. So left with others, if the doctor had not listened to the chest to know that there was bowel sound in the chest cavity, nobody would have even thought that there has been a damage through which the bowels have entered the chest. So that's why I'm asking whether if there are other clinical manifestations that the patient will exhibit for you to know that such a thing had happened to him. Thank you very much.
Yeah, thank you, ma'am. And that's why I said that it's almost like 60% is missed all the time. That is very difficult because the symptomatology will depend on the space-occupying lesion there, i.e., the amount of organs that go to the chest that will compress the lung affected will determine the symptoms. So the amount of intestine, the organ that go to the chest, not so much, and therefore compression on the lung so much, the patient may be okay. And I tell my students, my residents, that you don't need 2 lungs to survive. God was smart that anybody where the organs are 2, one is okay for you to survive. That's why you should be kind to donate 1 kidney for kidney transplant for somebody. You don't need the 2. 1 is okay. The same thing, you don't need 2 lungs to survive. And therefore, so many things can even go to the chest. They can compress that whole lung, collapse the whole lung there. If the other lung is doing well, there may not be symptoms at all. But there are 2 lungs there. So the same thing depends on how much organ. There are some laceration. I have to say, exactly, this fine laceration. Fine. That's what can be missed. There's a 13-year-old mixed, or what they call delayed diagnosis of diaphragm rupture. Diaphragm rupture, intestine was sitting in the chest 13 years later before they diagnose it. So yes, it can be mixed. And therefore, the extent depends on the amount of organ in the chest. And if the organs are not so much herniated, they may be fine. It will take a smart doctor to actually listen carefully to get it. That's why it is mixed in almost 60% of patients which are diagnosed actually in laparoscopy.
Please, thank you. I want to find out the financial burden of this surgery on the patient. That NHI is covered surgery. And approximately how much does it cost? And from Hanochi or Kolubi, do they have any arrangement to support patients in any way? Or are we even losing patients because of finances?
Yes, and thank you. And I'll just permit me say that. And sometimes forgive me, I shout to my patient for that. If I hear they don't have a health insurance, I get very worried. People have no idea until you go to theater, they realize the importance of the health insurance. You see, this surgery, if I do it on a normal scale, it costs 10,000, 15,000 Ghana cedis. If I have insurance as an emergency, the theater bill, it can be more than 3,000. You think you have insurance? The ward and feeding, the basic labs, your X-ray, laboratory, health insurance can pay almost 5,000 of the cost. If the health insurance is very important, if you don't have surgery, you don't realize that. The day something will happen that you have to the theater, then you realize how important. Me, as I never knew, until I started finding out when I started operating, I started finding out, oh, the cost, they'll show me, oh, this insurance are taking this, taking this. The insurance alone can take almost 5,000 of this cost. And the average is within 5,000, 7,000, the emergency. Elective, 10,000 to 15,000 Ghana cedis. So that if you don't have money, you can emergency, you have rupture, and you took the theater, you have to cough off between, depending on how many days you stay on the ward, how many days you stay on the ward. To between 5,000 to 7,000 Ghana cedis. But if you have insurance, you pay maximum less than 2,000. So please, if you are here, you don't have health insurance, you go and have it. Pray that nothing happens to you at emergency, or you don't need elective surgery anywhere. Very important. If you're university staff, then you are like a prof will take care of you. So that one is not a big deal. Thank you very much.
On the initial tubing or whatever proceeding, can we have an arrangement where some of these district hospitals, the clinicians over there, if you can, with your team, you can have training for them, because most of these accidents will happen on the highway. Otherwise, as you said, I like how passionate you have, or the passion that you have for your patient. But if at the place where the incident will happen, if the initial assistant, then they even lose the patient before coming to you. So
okay. You are very right, and thank you very much. You are extremely right, and we plan doing that. We haven't discussed. In fact, even recently, just about 2 weeks ago, we organized a session for even the new residents in pediatrics. I know that prof is here. Pediatrics, our own Community Hospital, pediatrics, we organize just 2 workshops for them. Just with it, so that when they come, the child comes with distress, there's a collection, and maybe I'm not around, my residents are not around, they should know how to pass. And like we are in the environment, I say you pass it, there's a complication. That's why the child setting is there. So we are thinking about it, and we plan doing that, and that's very important. Please. It's very, very important. We'll do that.
This is just a contribution. I think aside the clinicians, we can also involve the paramedics in our ambulance.
Yes.
I know Professor Zakaria is also doing well in that regard. Thank you.
Thank you very much.
Okay, I guess that was the last contribution. Thank you very, very, very much, Doc. And yes, on behalf of Prof. Deborah, co-chair, we'd like to thank you all for coming. It's been a wonderful session, and hopefully see you after lunch or tomorrow. All right, have a nice day. And please, our evaluation forms, if you have it, kindly give it to any of the ushers, or you can give them to me. Thank you very much.